Thank you, Ms. Chairman. Good afternoon, everyone. I think you're quite far away. I don't know, I have too much stuff. Probably I should come closer to you, because otherwise you're not going to listen to me. So, it's my pleasure to talk about virtual reality in education. And on the side of the slides, you can see where I come from. Not as beautiful as your islands, but quite nice and warm. And I work in London, which is a bit of a challenge. And that is me, because I was meant to do today a session live with virtual reality, but I didn't realize that there's not very many people on a Saturday night in London. Not even a patient, I think, are in hospital at the moment. So forgive me if I will give you a boring presentation. So what are the issues? What is the problem? In the 19th century, the reality was that medicine was learned most of the time at the bedside. Unfortunately, since that time, from 90% of the time, we went down to 75% of the time. And nowadays, actually, we spend only 17% of our time at the bedside. Why? Well, the problem is multifactorial. One is the working time directives. And I know that in Singapore it's not a problem, because you still work 80 hours, isn't it? But we reduce, at least trainee working less hours, have less time to spend at the bedside. There's shortage of staff. This is internationally known. Therefore, we have to do a lot of bureaucratic works than via the computer, and we spend increasingly less time at the bedside. The patients stay shorter. That's good. They go home earlier because we are good, but therefore, we have less time to spend with them and to assess them. They are more complex. Therefore, for instance, I work in a bariatric center. All the intervention, all the decisions are consultant-led, and these take away opportunities to trainee to learn and to spend time with patients. And sometimes, let's be honest, we are not trained. We don't have formal training for help our trainee at the bedside to teach them to learn how to learn medicine. So, we don't do very good use of the little time that you have at the bedside. And there are a lot of other reasons that don't allow us to stay at the bedside anymore. So, what is the problem? Well, the problem is that we still need to provide educations to adults. We still need to provide education that is reliable, like was in the past at the bedside. And how do the adults learn? They learn based on their experience. And the experience has a big influence, represents a big part of what they do at the bedside. They learn if they are involved. So if you make learning goal, if you decide what you want to learn about, they learn if this information you're giving them has immediate relevance. They can use the day after at the bedside. And they learn if the education is problem-centered. Unfortunately, we don't teach physiology anymore or biochemistry anymore from scratch. We want to make this into context to be relevant, because it's the way adults learn. Moreover, let's be honest, we get tired. We cannot stay seated for 4 or 5 hours like we were before studying in a book. And in fact, our brain is full of other ideas, other things we want to do, and children, families, and shopping and traveling. Therefore, we need to allow ourselves having some breaks. The only way for retaining information effectively is to learn at high concentration, small period of time, and then allow us to settle and have some break and think about other things and go back again. I will recommend you to read this book if you have time or interest in this topic, which is called Make It Stick. And this suggested you should use periodization, rest periods, and you should also use variable way to learn and to retain the learning. The other problem of modern education is all this series of competencies. The next speaker will talk about the Canadian experience. From my perspective, I've been involved in the European experience with doctors. And currently, the INACTIC project is looking at competencies for nurses in Europe, which is quite interesting and challenging. But all these series of competencies are more and more now focusing on not technical skills. So it's not just about putting a central line, but also learning something that can help you making decisions. Clinical reasoning is one of the most interesting, I think, aspects. And clinical reasoning is defined as a complex process that describes the ability of clinicians to use available data. So you have information history labs, and you have to make decisions. You have to make decisions sometimes fast in a complex environment for a complex patient. What does complex intervention, complex patient mean? What does it mean? Well, there's not a real good definition, but if I have to summarize, I can think that a complex intervention requires a number of difficult people, organization involved, difficult behavior are required to achieve the intervention, a number of variable outcomes are possible, and you need a degree of flexibility and variability to address the problem and to make the decision. We also know, and we have talked several times about the fact that high reliability industries address all the time the problem of complex intervention. And their skill is that they can do in a consistent way, even if the output is very high. So even if they have a full intensive care or a full emergency department, they can still provide consistent and safe performance. Do we do that? Not so well. And one of the reasons seems to be the fact that we don't train in clinical reasoning. We don't have time, we don't have the skills to train in clinical reasoning. Why? Well, let me give you an explanation. Diagnostic errors are very common. Those represent 8% of the severe adverse events registered in medicine, and the majority of errors made in surgery outside theater. So it's quite a big part of our work, quite a big part of our daily practice. Clinical reasoning, the reason for this diagnostic error are multifactorial. Nevertheless, by analysis of this diagnostic error, clinical reasoning represent a higher component, 74% of the case, which is even higher than the system mistakes. So we also concentrate on the fact that the system needs to be changed to prevent error, but actually we also need to change the way we think to prevent error. How many of you have received training in clinical reasoning in the course of their career? Anyone? How many of you ever heard about clinical reasoning? Yes, great. We got much, much more in this room. So the model on which is based clinical reasoning is the one of a dual process framework. So we work as in two systems. System one, don't say it's for the old one, it's for the wise one. It's for those people that have been experienced, worked for several times, so they are fast, they have an intuition, and they kind of perceive what's going on with the patients, and they make decisions based not just on the evidence, but also on their experience. You remember the way we learn as adults is based on experience. And then there is system two, that is our trainee. They are much more knowledgeable at times, they are slower, they are analytic, they go through all the data available, and they make a decision. This is because they have not developed the intuition or the knowledge that we have with time and with exposure at the bedside. But what we said at the beginning of the talk, that this exposure at the bedside is now down to 17%. So how many years do a trainee need to develop this clinical reasoning? Has this an impact on diagnostic error? Has anyone looked at that you are aware of? Well, we believe that even if we don't have so much exposure at the bedside, we currently have high technology and several ways to address this problem. And one of these ways is virtual reality. The system one suggests that you can develop your skills by being exposed, first of all, to typical case. So several times you see the classical presentation of the patients with diabetes, up to the point that you don't need to go to see all the labs, but you can recognize the case by presentation, by history, faster. And you don't need to be reassured by all the analytical evaluation of the information, but you can make this assumption quite reliably. You can have feedback. You need to have feedback because your intuition, even if you are quite certain, is not so strong up until you don't have feedback and you have someone, or you have the system that supports you and convinces you that actually you are safe to make decisions in this manner. System two, therefore, needs exposure to a typical and then atypical case and needs time. But sister one can also become sister two. Let's think about when you have the strange case of a patient that you believe maybe is COPD, but probably he has no stridor, has secretion, you're not sure, you never saw it before, or maybe the patient comes from a country that has diseases you have not been treating. At that specific moment, even an expert intensivist moves from system 1 back to system 2. You become analytic, you become slow, you go back to the computer. So even for system 2, for system 1, it's sometimes beneficial to be exposed to virtual reality, to other technology, to go back and to learn about atypical cases. So can virtual reality help? It was not the case a couple of years ago because effectively the cost and the time for providing good education were very high. Nowadays, the cost of a camera and of the equipment is decreasing significantly. The skills of our trainees are increasing significantly. It's becoming more and more common to have this technology in any university. Therefore, I think the attention, the goal needs to be on how can I use and when can I use and what can be the special goal or special need addressed by virtual reality. Of course, virtual reality cannot give you all the curriculum, but there are specific areas that are extremely important and can benefit from this kind of approach. So, as I said, my idea was to come here and give you a technical example of what we do at Imperial College. But on Easter evening was a little bit difficult. So I spent all day working for you and going around Singapore because I'm sure that you can find in Singapore all you need. And I was looking for virtual reality so you can have a feeling of that, even if you are not going to be in London. And this was exactly there, where Netflix created this virtual reality, and it was for free, I would recommend you to go, virtual reality setting, where you can walk on different parts and a different consistency of the planet, from ice to snow to, and it's the same. You can do the same, entering in a room with the scenario of your patient and assessing your patient. Similar type of approach, very easy. You can do with the Googles, but you can do also for those that don't believe is good for their equilibrium with a screen. I know sometimes the goggles can be challenging because of hygiene, because of vertigo, and because we're getting old, I'm afraid. Anyway, so let me give you an example before I close this part. This is what we're doing with Rapid Response System. We had a conference, for those that were not here, based on deteriorating patients. And during that conference, we discussed about how important it is to recognize patients in the world that are getting sick and to refer them to a group of experts. But how do you do that? You have the classical environment where you have very few nurses, very unskilled people, they are not familiar with the image of a critical illness, and yet they need to make the decision of calling for help. That's not easy. That's quite difficult. Have you ever heard about normalization of deviance? Any of you? So this is a concept that comes from sociology. It doesn't come from medicine. Normalization of deviance is a situation by which, if you are in a system, you know you're doing something that is not correct, but you're in that system, so that's normal. You don't wash your hand every time because, yeah, you're in a rush and your colleague in the bed next to you doesn't do that any time. So, okay, for today I don't do it, I do it tomorrow. But then if you walk outside the system, you see that this is something wrong and you should not be doing. And this happens every time. And this is a very big problem because sometimes we don't make decisions that we find right, especially nurses, more than doctors. They don't make the decision of calling for help because they feel scared or they feel in the system is not allowed. So they know that is the right thing to do, but in the system, the deviance suggests it's better not to do, it's safer not to do. And this has happened every time. And virtual reality for us has been very, very important because we use that to train nurses in the world to make decisions and to recognize the patients who is deteriorating. Why is this important? Because these are two very recent publications showing what type of patients deteriorate in the world. The patients that deteriorate and come to intensive care are the sickest. That those that deteriorate go to the ICU are 30%. 10% die in the day. And 29% die within 30 days. So these patients you want to recognize and you want to trigger and refer to a specialist are the sickest of the hospital. What do you use? In England, we have the news score that has been assessed and is quite efficient, has been recommended to be used in all the hospital. It's a quite easy score if you look at that. There's not very many things to calculate. But you know, respiratory rate for a busy nurse in a department might be very difficult to calculate. What did we do? We decided that, and also, sorry, this other study shows that up to 20% of the time, the calculation is wrong. And if you calculate that wrong, this has an impact on patient's outcome. When is that calculated wrong? Can anyone guess which day of the week and which time of the day the calculation gets worse? Anyone? Night shift? Anyone else? Which day of the week? Easter? Sunday? Saturday? Therefore, you need a system one to make this work. And this can be relevant because this impacts patient's outcome and avoids diagnostic error. We were using virtual reality and for allow the nurse to come into the space, into the bedside space. The system was previously developed by our surgical department, where surgeons learn how to assess the patients, how to introduce themselves. The skills that the surgeon wanted to develop was professionalism. So we took the same image with the same scenario, and we just add the score, the parameter in the news score. You know? Very simple one. Respiratory rate, saturation, blood pressures, consciousness. Very, very simple things that people forget to do or don't do that well enough. And we get the doctors and nurses to come into the environment. It's only 5 minutes to calculate the score. Very simple. And then we ask them what the response to the score is. Calling for help, making more close observation. It's a very simple, very straightforward, very, I must say, not very, but relatively cheap intervention that can be used to improve and to prevent error. Has a direct impact on outcome. There are lots of companies that do that in England, the startups. They're relatively cheap. This is one we've been working with, and you can see you can have space. You can have. We did real simulation, low quality simulation, but it's not become any more challenging. In Imperial College, we are now working on the concept of a virtual patient so that we can teach our medical students to collect medical history, which is quite something important because of, as I said at the beginning, the lack of time. We don't do as well as we should do because we really have to run and to rush too much to make it properly done. So I think virtual reality in education fits the concept of adult learning. Virtual reality in education fits achieving some of the new competencies of any curriculum in training and sits with patient safety, which is something that I think high quality, high reliability organization need to focus more and more on. If you work with system changes, like a rapid response, you will realize very quickly that putting in place a team does not make any difference. Even if you have the most skilled, the best trained people that can resuscitate virtually everything, and you put them in a hospital, they will not make any change unless they're integrated in a system. So multidisciplinary, multi-professional training, not at the bedside, but in a realistic environment, is increasingly needed. If you want your organization to become high quality, high reliability, you need to think about the design. And you need to, and we quickly learned, as specialists in the critical environment, that if anyone can make an error, it's sure that someone will make it. So think about the design when you organize your training, your teaching. And I would like to conclude with this sentence, which is from an Italian that is even older than me. And I like to think that learning is the only thing the mind never exhausts, never fears, and never regrets. Thank you very much for your attention.